Hello everyone, it's Dr. Rehan Ali Mondal here. So today we'll be doing a class on history taking. So before we start, let me give you a quick review of how your examination will be conducted. So in final year, in practical exams, each of you will be getting a case based on one specific system. So if suppose someone might present to you with neurological manifestation, then you have to go towards CNS examination. Someone is presenting to you with respiratory distress or respiratory system disorders, then you have to examine the respiratory system. Someone is presenting to you with abdominal problems, then you have to go for the GIT examination. And if someone is presenting to you with heart disorders, the chest pain and all, then you have to go for cardiovascular system examination. Okay, so there goes the systemic examination, the specific systemic examination. But before a specific systemic examination, two things that you need to do is history taking and general survey. So all the students have to do history taking and general survey, but after that each student will be allotted one individual case. So then you have to do any one of those specific 4 systems that I mentioned. So first, coming to history taking. So what is history taking? So when you go to a doctor, the first thing that a doctor does is he talks to you. He doesn't straight away go on examining you. Okay. So history taking is that part when someone is just talking to you and not yet touching you or examining you. History taking is we're trying to understand why are we doing all these things. We are doing all these things to go towards a provisional diagnosis, because only once if we are able to diagnose a disease, then only we'll be able to treat a patient. So history taking is just talking to the patient and trying to getting to know his problem, so that we might narrow down our vision to one particular disease. So history taking has some headings and subheadings, each of which has its own significance. So first I'll tell you the broad headings, then I'll go into discussing each one. So the first one is patient particulars. Let me tell you the headings first, then I'll go into each one. Then we have chief complaints. Then we have history of present illness. Then history of past illness. Then we have personal history. Addiction history. History, and these are the major. Okay, now when it comes to history taking or anything in medical field, so there are various books out there. Okay, so some books might prefer putting one part under this heading, under history of past illness, or some like for example history of comorbidities, that is sugar, pressure and thyroid. Some books might prefer to put it under history of past illness, some books might prefer to put it under history of personal history. It really doesn't matter under which particular heading you put each point into. What matters is at the end of the history taking, you should have all the important information, so which will help you to your diagnosis. Okay, so little if haywire goes, like if you're putting this point under this heading and this point under this heading, until unless it's a gross change, it really doesn't matter. So till here it's family history. Apart from this, we have functional history, and some books also mention about treatment history. Then again, if you're mentioning the disease in history of past illness, then treatment history doesn't stand any importance. Then along with that, you have drug and allergy history. And then some books also mention about psychiatry history or psychological history. Now these are the major points of history taking. Now I'll go into each one of them one by one. So now coming to patient particulars. So what are patient particulars? There are some subheadings. First is, each of them has its own significance, and I'll go on telling what are the significance. First is name. Why is name important? Two reasons. First is patient identification and doctor-patient relationship. Okay. Apart from corporate hospitals or private hospitals, when you go to a primary health center or a government hospital, you'll see it's completely crowded out there. One bed is not only allotted to one patient. You'll see 3 patients lying on the same bed. You'll see patients lying on the floor. So before any procedure, before giving any injection or giving any drug or any procedure, you need to first confirm that this is your patient that you're treating. Okay, so that is why name is important for patient identification. And then again, doctor-patient relationship. If you call someone by their name, it builds up a nice, better relationship than just calling him like patient come here or something like that. Okay. Then next is age. What is the significance of age? We have diseases divided according to their age group. Like some diseases are more prone in a particular age group. That is why the age is significant. For example, we have pediatric diseases, we have geriatric diseases. For example, carcinomas are more common in the elderly age group. Then rheumatic fever is more common in younger age groups. Then cholecystitis or appendicitis in more or less in the middle age group. So that is why age also gives us an idea to whichever disease we are thinking about. Next is sex or gender. Now gender also gives us an idea about to thinking whatever disease it is. For example, if someone is presenting to you with right lower abdominal pain, so in case of a male, you'll think about appendicitis. Okay, right iliac fossa pain. In case of an male, you think about appendicitis. But if that same pain if a female presents with same kind of pain along with appendicitis, in the differential diagnosis, we also have to think about diseases related to the right ovary too. So that is why gender also has a bias. Next is occupation. Now, people might have heard about the occupational hazards like asbestosis, silicosis, which are more prone to the occupation that a person is working into. If he's inhaling harmful fumes and all, it might cause lung diseases. Then again, suppose if someone is working in a heavy metal factory where there is continuous beating of the loud iron noises and all, so that can damage the person's tympanic membrane, then we'll have to think about ENT diseases. Likewise, occupation has a significance. Then suppose if someone is involved in lifting heavy objects or heavy physical strenuous work and the patient is presenting with hernia, so we'll think that this is the cause of the hernia. So that is why in that way it helps us to narrow down to a disease. Next is address, or the place where the person is living. This also has a significance. For example, suppose in times of COVID only, if someone in the initial days when the first wave started, we were thinking that if someone had a travel history to China or someone was coming from China, we were considering and had fever, we were considering them a suspect of COVID. So the area address from which he was coming gives us the significance of the disease. Then in monsoon season, the states of West Bengal, Bihar and Jharkhand, they are more prone to diseases like dengue. Then encephalitis is more prone in West Bengal. So likewise, address, the place from where a person is belonging to, also gives us an idea the disease he might be having. Then is religion. Significance of religion, it tells us about the socio-cultural practices of that religion. For example, in Jews and Muslims, they undergo circumcision at a younger age group, which reduces the chances of penile cancer, and many other socio-cultural practices which might help us to narrow down to a disease. Then we have date of admission and date of examination. Date of admission is the day in on which the patient got admitted to the hospital, and date of examination is today, the day when you are examining the patient. What is the significance of these two is, suppose there is a huge gap between the date of admission and date of examination. Suppose there is a 10-day gap or 1 week gap and there are no improvement of symptoms. Suppose someone presented to you with pain in abdomen 7 days back, and today you are examining the patient, he has the same amount of pain. So this will give you an idea about the prognosis of the disease. If there is no symptomatic improvement, then we'll think that the prognosis is bad, or the disease, the diagnosis that we are thinking about might not be the case. Then we have to think about other diagnosis. Okay. And last is bed number. The bed on which you are examining the patient. So, name, age, sex, occupation, address, religion, date of examination, date of admission, date of examination, and bed number. These are the basic points in patient particulars in a general medicine or surgical case. But if you go to pediatric or obstetric or gynecological cases, along with this, it has a few more points like menstrual history, age of marriage, history of fertility, anything, things like that. That gravida parity, that I'll cover in another video when I'll be specifically talking about obstetric and gynecological history or pediatric history. For a general case, these are the points. Now next, coming to chief complaints. Now what are chief complaints? So I don't have space here, but let me just tell you. So what is chief complaint? Chief complaint is the primary complaint with which the patient is presenting along with duration. It is written in very short, and chief complaint is always mentioned in chronological order. Either it's ascending or descending. For example, suppose someone is having pain in abdomen for 7 days, vomiting for 5 days, and headache for 3 days. So you go in that order. Abdominal pain 7 days, vomiting 5 days, headache 3 days, or headache, vomiting, abdominal pain. You can't go like abdominal pain 7 days, headache 3 days, then vomiting for 5 days. You have to follow an order, either it's ascending or descending. So chief complaint is the primary complaint with which the patient is presenting to you along with the duration for which. So suppose if someone is presenting to you with pain in the abdomen, so your chief complaint will be pain in the abdomen for the past 5 days. Now, what kind of a pain, where the pain is radiating to, are there any aggravating or relieving factors, we don't need to mention in chief complaints. We'll come to that in the next heading, but in chief complaints your only focus is the primary complaint with which the patient is presenting to you, and along with the duration. Now generally in surgical cases, most of the people will get pain abdomen. I'm mentioning few of the chief complaints that you might be getting in your exam. Then you'll have vomiting, fever, some might present with a lump in the abdomen. Then in medicinal cases you'll get cough, fever, all those things. Now here I'll just mention about one point. Next, coming to history of present illness. Now what is it? History of present illness is, this is elaboration of chief complaint. Whatever chief complaint that you've mentioned, be it fever, vomiting, pain, whatever you've mentioned, history of present illness, here is the point where you elaborate that point. For example, I'll just quickly teach you how to describe pain. Now suppose if someone is presenting to you with pain, then how will you describe that in the history of present illness? I'll make a separate video about all the other chief complaints, like what all, how will you elaborate fever, how will you elaborate vomiting, how will you elaborate cough, and all those things. Here I'll just give you a quick example about pain. So when it comes to describing pain, there is a mnemonic to describe pain. It is Socrates, S-O-C-R-A-T-E-S. Now from S, what do we have? Sight. Now your for example, abdominal pain. Now your abdomen is divided into 4 quadrants and 9 regions. Remember, it is not divided into 9 quadrants. Quad means 4. So 4 quadrants and 9 regions. What are the 4 quadrants? Upper right, upper left, lower right, lower left. Simple. but 9 regions is what is the difficult part. So what are the 9 regions in which abdomen is divided into? So there are 2 vertical lines and 2 horizontal lines which divides our abdomen into 9 regions. Okay, so these vertical lines go from the mid clavicular point to the mid inguinal point. Left mid clavicular point to mid inguinal point, right mid clavicular point to mid inguinal point. Okay, easy. Mid clavicular point to mid inguinal point, mid clavicular point to mid inguinal point. 2 vertical lines, easy. Now the horizontal lines. Now there are 2 planes. One is the Trans-Pyloric Plane and another, the lower one, is the Trans-Tubercular Plane. Now how do you define these planes? For Trans-Pyloric Plane, you ask your patient to do like this. You take his hand and this knuckle of the thumb, you place it over here. How? This knuckle should touch your xiphisternum. Xiphisternum is the lowest point on the sternum. You have the sternum bone here, the lowest point is the xiphisternum. So this knuckle should be touching the xiphisternum. And the plane passing from the lower level of your hand is the Trans-Pyloric Plane. Now this plane, here is your costal arch. The arch of your rib cages, this is known as a costal arch. So this plane passes through the tip of the 9th costal cartilage. Okay, so you ask your patient to do take his hand like this, place it over here. This knuckle should be touching the xiphisternum. The plane passing through the lower border is the Trans-Pyloric Plane. Another way how you can do this, show this plane, is ask the patient to lie down and you ask him to raise his leg, straight raise his legs, like without folding at the knees. When he raises his legs, his rectus abdominis muscle gets tightened. So the place where this rectus abdominis muscle, the rectus abdominis muscle is a straight muscle like this in front of the abdomen. So the place where this rectus abdominis intersects this costal arch, this point is your tip of the 9th costal cartilage. So you get both the tips of the 9th costal cartilage and the plane passing through it is the Trans-Pyloric Plane. So you understood the Trans-Pyloric Plane? Now next is the Trans-Tubercular Plane. Now when you palpate over here, the first bony prominence that you are feeling is your anterior superior iliac spine. Now you go, on both sides there are 2 anterior superior iliac spines. Now you go 5 centimeters behind the anterior superior iliac spine and you'll get the iliac crest. The plane passing through the iliac crest is your Trans-Tubercular Plane. Okay. So this is mid clavicular point, right, then this is left mid clavicular point. This is right mid inguinal point, left mid inguinal point. This is pyloric plane, Trans-Pyloric Plane, and this is Trans-Tubercular Plane. Understood? Now this divides the abdomen into 9 regions. The topmost one in the center is epigastrium. Below it in the center, umbilicus. Below it, the center part, the lowest one is hypogastrium. Now to the right of the epigastrium is right hypochondrium. Right hypochondrium. You might pause the video and write down the names of this diagram. Okay. Next to the left of epigastrium is left hypochondrium. To the left of umbilicus is right lumbar. To the right of umbilicus, I'm sorry. And to the left of umbilicus, you will have left lumbar. Now to the right of hypogastrium, you have right iliac fossa and you have left iliac fossa to the left. So these are the 9 regions of the abdomen, starting from the right side. Topmost corner, right hypochondrium, epigastrium, left hypochondrium. Coming to the center part, right lumbar, umbilicus, left lumbar. And the lowest one, right iliac fossa, hypogastrium, left iliac fossa. Now what is the significance of dividing the abdomen into these 9 regions? Now suppose a patient is presenting with pain in whichever region. Now that pain will be related to the viscera or the organ lying underneath it. For example, if someone is presenting you with right hypochondrium pain, you'll think about gallbladder pathology, you'll think about right lobe of the liver pathology. Someone is presenting you with epigastrium pain, you'll think about stomach pathologies. For example, gallbladder cholecystitis, stomach pathology, you will think about gastritis. Someone is presenting with the right iliac fossa pain, you'll think about appendix pathologies, appendicitis and stuff like that. So there's a beautiful list that Dr. D.K. Roy has given us. I'll put that there, upload it there so you guys can see it. We really like the site where the pain is originating and the related viscera to it. Now next is onset. Now, onset might be sudden or gradual. So we have two types of onset. That is, I don't have space here to write down, but it will be sudden or gradual. Whether you'll ask the patient if the pain was like if you're asking in Hindi, it will be आपका दर्द अचानक से आया या आस्ते आस्ते बढ़ा. If you're asking in Bengali, then আপনার ব্যথাটা কি আস্তে আস্তে হয়েছিল, আপনার ব্যথাটা কি হঠাৎ হয়েছিল নাকি আস্তে আস্তে বেড়েছিল. So the onset. Next, C for character. Now there are some specific characters for the pain. For example, you might be having colicky pain, you might be having dull aching pain, you might be having throbbing pain, stuff like that. So these are the ones that you might be encountering in a patient for final year exams. Colicky pain is like it's when there are some disorder in a luminal structure, and when it contracts, then you have colicky pain. Patient might tell you amar kamre kamre ব্যথা হচ্ছে in Bengali. Dull aching pain means pain which is more or less persisting always. Throbbing pain is more like a pulsatile pain, throbbing in nature. Okay. Next, R is radiation, migration, or referred. Radiation, migration, or referred. Now understand the difference between the three. What is radiation and migration? First, coming to two. Now in kidney pain, you might have heard that the pain radiates from loin to groin, means from behind to the front. Now in radiation, what happens? The pain starts at one side, then it moves to another side, but the initial side, the first pain side where the pain started, the pain persists over there. The pain is still there. The pain radiates from loin to groin, means there is pain in the loin, and along with that there is now new pain in the groin. So pain present at both pain sides. But in migration, what happens? The pain migrates from one place to the other. So the first pain site where there was pain, there is no more pain over there. There is only pain persisting in the second pain site. Like it's migration, when someone moves from one place to the other. So in radiation, the pain is present in both the sides, that is the first pain site and the second pain site. But in migration, it is present only at the second pain site. The first pain site where the pain initially started, there is no more pain in there. Now what is referred pain? Referred pain is pain at a site where there is no pathology, but due to the same nerve supply. For example, let me make you understand this with an example. Now suppose someone is having an abdominal pathology in which the diaphragm is irritated. Suppose he has a gallbladder pathology or something for which there is inflammation, infection, the diaphragm is getting irritated. Now the diaphragm is supplied by the C345 nerve. Okay. Now along with the diaphragm, our right shoulder scapular region, this part is also supplied by C4, C5. Now what happened when there is abdominal pain? When there is abdominal pain due to which the diaphragm is getting irritated, the shoulders will also pain, right shoulders will also experience the pain. Why? There is no pathology over here, but due to the same nerve supply, that is C4 common, C5 common, due to the same nerve supply, this right shoulder will also be having pain. This is called referred pain. So pain at a site where there is no pathology, but due to the same nerve supply, that is referred pain. Okay. Now A for aggravating or relieving factor, and relieving, not or, and wanted to do this class in a tablet, but or a laptop, I couldn't get hold of it, so this blackboard. Anyway, so A for aggravating or relieving factor. So what are these? How will you ask the patient? You'll ask the patient if on doing anything his pain is increasing, or if on doing anything his pain is getting reduced. For example, in stomach ulcers, gastric ulcers. What is ulcer? Ulcer is like जैसे छिल जाना होता है आपको, जैसे स्किन पे बाहर जो आप छिल जाता है आपको, when you touch that place you get hurt, like that only. When there's an ulcer in the inner lining of the stomach, you have your stomach here, there's an ulcer there. So when you take in food, the food goes and touches that area of the ulcer, it irritates it, and the patient feels pain. Along with that, when there is food in the stomach secretes HCl. When this HCl comes in contact with the ulcer, it again irritates it and causes pain to the patient. So intake of food is an aggravating factor for pain in a gastric or the stomach ulcer. Understood? Now, relieving factor. Now, it is said that in duodenal ulcer, intake of food relieves pain. Then again, some patients might tell you that on his pain was reduced on only taking medicine. दवा खाने पे उसका दर्द कम हुआ, ओषुध खे और ব্যথাটা কম হয়েছিল. In that case, you will mention that the pain was relieved on medication. Another example that Dr. D.K. Roy gives is that in pancreatitis. Now, pancreatitis is located a little posteriorly. It's not a retroperitoneal organ. In the peritoneal cavity only, it's located a little posteriorly. So, when the patient is sitting like this, there is visceral crowding there. The pancreas there's inflammation, the pancreas is a little increased in size, there's infection. When all the viscera press against it, there's pain. But when the patient does this, like he takes a pillow here and he curls up like this and then there might be some relief, because when the patient is doing like this, the viscera gets spaced out, the pancreas get a little space to expand, then there is relief. So in pancreatitis, curling off with a pillow like this gives some relief to the patient. Like this, there might be various aggravating and relieving factors, like in peptic perforation or peritonitis, the patient prefers to lie listless and stuff like that. Next is type 2, that is continuous and intermittent. Continuous pain means the pain is persisting always. Intermittent pain means pain is coming and it's going. Quickly I'll give you an example. For example, you've seen the urinary bladder, right? It's more like a triangular organ like this. So when there's a stone in the urinary bladder, some stones, they float on the urine. Okay, so suppose this is a stone which is floating on urine. Now when the person passes urine, when the stone is floating on the urine, the patient feels no pain. But when the patient passes urine and this stone settles on, the moment the stone comes in contact with the mucosa of the urinary bladder or the inner lining of the urinary bladder, it irritates the mucosa and the patient feels pain. But again, when there is accumulation of urine and the stone floats up, the pain goes away. So this pain is like coming and going, intermittent kind. Now, but suppose this same stone was impacted in the kidney. Solid organ kidney, the stone is not able to move here and there. It's always touching the mucosa, and in that case, the pain will have, person will have continuous kind of a pain. E for, I prefer to write E as like the mnemonic, according to the original mnemonic of Socrates. E is exacerbating factor, but exacerbating factor we already covered as aggravating factors. So for E, I prefer to mention is estimated duration. The duration for which the patient is having the pain. And last S is severity. Now clinically severity is not that, like it is important, but severity again is a subjective matter. Like some people might have a lot of pain but they're able to withstand it, and some people might cry in little pain only. So it's more like a subjective matter. What is important for pain description is site, onset, character, for radiation, migration, referred, aggravating, relieving factor, type. Till here it's very important. Severity and duration, yeah, it is important. You're already mentioning in the chief complaint about the duration, and this severity is more like a subjective matter. So pain needs to be discussed under these headings. I'll make separate videos for all the other chief complaints. This video will get long enough. After that, history of past illness. I'm rubbing out this part a little, okay? So I'll get space to write. Hope you've copied everything or you can just pause the video and copy. Now, history of past illness. Now, some books recommend that you take the history of comorbidities. Like comorbidities, when it comes to comorbidities, during the time of COVID also you've heard, we talk about three things, that is diabetes, hypertension and thyroid disorders. So some books recommend you take the history over here, history in past illness, or you or take it in personal history. So in history of comorbidities is three things that I mentioned, that is diabetes, hypertension and thyroid. In that you specifically ask the patient कि आपका sugar, pressure, thyroid कुछ का दवा खाते हैं आप regularly, then if the patient takes the medicine they'll mention it to you. Along with that, past history has 2 points, that is PMH and PSH. Past medical history and past surgical history. Whether the patient has had any major medical histories in the past or any surgical histories in the past for which he might have got admitted to the hospital or might have got aggressive treatment at home itself. Might be related to this or might not be related to this, but it's important you take that history. Okay. Next, coming to personal history. In personal history, the thing that I mentioned, either you can put the history of comorbidities over here or personal history. Along with that, it has 4 separate points, that is bowel, bladder, sleep, appetite. Bowel means whether the person is able to pass stool or not properly. Suppose someone might be having constipation or someone might be having loose motion. So bowel, if the patient is able to pass his stool clearly or not. Bladder, if the patient is able to pass his urine properly or not. Sleep, if the patient is getting adequate amount of sleep per day. Appetite, if the patient is